Good evening, Dr. Ayyappan.
Good evening, sir. Hi, sir.
I think we can start. Let people join. What do you say, Mr. Jaishankar?
Yeah, I think we can start. Yeah.
Okay, good. Because we have the presentation, I don't want to take that time. Good evening, everyone. I'm Saraswati, Secretary General of the Madras Chamber of Commerce and Industry, and it gives me great pleasure to welcome Dr. Srinivasa Rajagopala and all the participants, committee members here. Just to give a very, very brief introduction about the chamber, for those of you who are new to this virtual platform or the programs of the chamber, this is 187 years young chamber. We were started in 1836, the oldest in southern India, the oldest in Tamil Nadu, second oldest in the country. If we take the Bombay chamber, which was born 1 week ahead of us into consideration, we are the second oldest. And we have a lot of expertise, and we have remained very, very aligned to the requirements of the members. That is the reason probably we are able to sustain this long world over. Not very many organizations could do that because of the chambers, probably the tuned to the requirements of the members, and probably keeping abreast of the current developments and the requirements. I should say that probably we are able to sustain this long. And we have as a great support our general committee, and also a number of expert committees for different domains. We have around 13 expert committees, to be very precise, 4 working groups and a women business council. So that way, the healthcare committee, though we have been doing a lot of activities under the healthcare space for some time now, somehow the committee was not formed. So the committee was very recently formed, and we have Mr. P.V. Jaishankar as the chairperson of the healthcare committee and Dr. Ayyappan Ponnuswamy as the co-chair. And we have very, very learned expert members in the committee. Some of them are joining today. So technically speaking, probably this is the first program after the healthcare committee is formed. So I would stop here. I would request Mr. P.V. Jaishankar to introduce the committee and also have the privilege of introducing the speaker of the day. I would only request all the participants to keep your audio and video on mute when the presentation is on. Maybe we will open up for the question answers after the speaker finishes his presentation. You can also in the meantime post your questions in the chat box. So we look forward to hearing to you, Dr. Srinivas Rajagopala. And over to you, Mr. Jaishankar.
Thank you, Saraswati, and a very warm welcome to all of you in this seminar. It's very warm outside, and I'm sure this seminar will kind of stimulate the interest we wanted to generate, given the eminence of the speaker we have. Just a brief background about the Healthcare Committee. As Saraswati said, this is the first formal event. We have been doing a lot of events before this, but on the subject of healthcare, but this is the first formal event after the Healthcare Committee. Formed a fairly diverse community of doctors and medical administrators in the committee. Dr. Ayyappan Ponnuswamy, the medical director of Kaveri Hospital, Dr. Ajit Mulaseri, the cardiology director of Triple M Hospitals, Dr. E.S. Krishnamurthy, founder chairman of Buddhi Clinics, Mrs. Gayatri, the CEO of Curie Hospital, Dr. Aarti, the founder director of Aarti Scans, Dr. Mohan Shankaran, the head of the Healthcare Technology Incubation Center of IIT Madras, to represent the academia and technology side of things. Dr. Rava Raghu, clinical lead at Buddhi Clinic. I don't know if I'm missing someone, and we are going to be adding more. The whole objective is to have a fairly diverse healthcare committee which respects all aspects of healthcare. We will be adding eminent people from the pharma industry, the health insurance industry, the holistic health and lifestyle diseases side, the non-traditional, non-allopathic, the traditional health kind of representatives. Tamil Nadu is a very, very rich medical ecosystem in the country. The objectives of this committee are fourfold. One is to kind of facilitate with the state government to ensure that Tamil Nadu stays on top of the country in terms of quality of healthcare, in terms of affordability of healthcare, in terms of access to healthcare. And towards that, we'll be working closely with the state government. Second is to provide a forum for all healthcare institutions in the country to interact with, in the state rather, to interact with each other and kind of exchange and help each other wherever required. The third is to bring together the larger healthcare institutions and the smaller ones to enable bootstrap the smaller ones to benefit from the experience, the technology, and the abilities which are shown by the bigger institutions. And finally, to disseminate information on subjects of common interest and topical interest to the public. We'll be having events almost every month with some informal small events, some big events, and we'll be kind of working closely with the Chamber of Commerce. A special thanks, in fact, to the President of the Chamber, Mr. Keshwan, and Secretary General, Mr. Saraswati, who were kind of instrumental in driving the setting up of this healthcare committee. So I really look forward to interacting with all of you. And who better to start today's program than eminent doctor like Dr. Srinivas Rajagopala. Dr. Rajagopala is a senior consultant of interventional pulmonology and sleep medicine and the director of transplant pulmonology and lung failure unit at Kaveri Hospitals. He has more than 19 years of experience in pulmonology, critical care, epidemiology, and transplant pulmonology from various national and international level institutions. He has published a lot of papers. and is a professional member of the American Thoracic Society, the European Respiratory Society, apart from the Indian Society and the Indian Society of Critical Care Medicine. His primary expertise is in donor lung assessments, lung perfusion assessment studies, evidence-based management of lung diseases, especially in interstitial lung diseases. And I think one of the major reasons we thought Dr. Rajagopala will be very relevant in today's session for COVID is I think we have seen COVID being particularly impacting of the lung and the heart over the last few years. Starting from knowing nothing, we are actually now learning a lot about the impact COVID has had over the last 19 years and the ups and downs we have faced over the years. So I'm sure with a very capable and competent background, Dr. Rajagopala will help us understand a bit more about COVID. The primary focus, as we said in the topic of the session, is COVID keeps coming and going. How long will it keep marching on for us? Is there something, what are we as a general public, what should we take care of or should we be aware of? Okay. And of course, newer vaccines are coming out. And what is new about these vaccines? How different are they from what we have all gone through? There are some of the areas, and I leave it to Dr. Rajagopala to kind of enlighten us and give us a background on the specific subject of COVID-19. Feel free to touch upon the lung side, the pulmonology side of things, Dr. Rajagopala. Okay, don't let the topic constrain you too much. Thank you so much. Welcome once again.
Thank you so much for inviting me, sir. Dr. Jaishankar, Mr. Jaishankar, Mrs. Saraswati, and it's a real pleasure to be here. And actually, I tried to let me first get up my slides before we. I hope I'm able to. Yes. All right. So for the purpose of this talk, my idea is to basically give a bird's eye view about COVID-19 in 2023, like 2 years after, more than 2 years after the pandemic started. So why we still here and where is this likely to go, and touch upon a few of the other things. But I'm happy to take specific questions because now the literature on COVID is so large that for a non-specialist, even as a physician, it might be often difficult to keep up with what's happening. So why are we now, after almost 2.5 years after start of the pandemic, still talking about COVID? For example, we don't talk about so much about tuberculosis for that matter. So this is primarily because of the heightened awareness and what trauma as a society we've gone through, and then this happened or is rather happening now as we speak. A spike of cases happening over the last month. Almost all big states having a spike in the number of cases, consequently spike in the deaths as well. So everyone's questioning, are we now on the fourth wave or whatever wave number are we there? So which is why this topic is also timely. So in the context of where we have been with regard to COVID, if you look at the first case, and then the initial lockdown and the first wave after the lockdown was open, we did have a small bump there. You can see the peak total cases during the first wave was short of 1 lakh, and it lasted about 2.5 to 3 months and then settled down. And then in April 2021 is where we had the brunt of COVID in India. Most countries had this at different time points, depending on how much transmission was happening, how much lockdown was in place, and those kind of things. Bear in mind that we still didn't have any effective vaccines till about September, November of that year. So the second wave anticipated availability of any vaccination or efficient rollout of vaccination at that point. So we did have, major trauma as a society, huge number of cases, healthcare systems being overwhelmed, a lot of deaths, several of them, several thousands of them probably preventable. But this is what happens when systems are kind of overwhelmed by a pandemic disease. And then that did die out slowly. And in January of 2022, we did have another huge spike in number of waves. Fortunately, this was driven by another variant, and Fortunately, we didn't have as many, which I'll come to that next slide. We didn't have that many things, and then that kind of settled down. And then in April 21, you can see a small bump up towards the end of this as we speak, an increase in the number of cases. The peak of this wave or so, if you chose to call it, around 10,000 cases. And fortunately, as we kind of hoped already, this is kind of settling down now. The case load numbers have already dropped below 7,000 today. So well on its way to now settling down this particular spurt in the number of cases, you should call it probably. So as a society, more than the peak number of cases now, now that we're actually living with COVID, what matters more for us is actually how much havoc it's really caused in terms of not only, of course, mortality is one gross way of looking at it, but also morbidity, healthcare expenditure, and those kind of things. And you can see, compared to, say the Delta wave in April 21, you can see that there is actually no bump in the number of deaths at all as we speak here in February, April. There have been, there are about 40 odd deaths in several large states, but comparatively, you can see that, compared to where we are, this is data from WHO as well, just to show you the total number of cases as well as the total number of deaths, that this has not been such a problematic scenario compared to the other three waves that we've had. And like I said, it's already on its way out, and this is where we are with regard to this current spike or a spurt in the number of cases. Like you can see, almost all large states have at this point reported an increase in the number of cases, and of course Kerala as usual punching way about its weight, and then Maharashtra, UP, and of course Tamil Nadu. Fortunately, like I said, the number of deaths have been pretty low. You can see here, and several components of this data that is published by the health ministry is very relevant to us. In this board, you can see, for example, here the total number of cases that you roughly we kind of you can see that the total number of tests that have been done on this particular day, say for example, when I took this data out, was about 2 lakh, and on that particular day we had about 12,000 odd cases reported. So you can see that the test positivity was about 6% at that point. We know that if the test positivity is about 3-4%, then there's significant under testing happening, which is likely, especially now we're so a lot of people are kind of so over it. So we can anticipate that what this means as a case load denominator is that because there's underreporting happening, so the case load is likely to be double this the number at least. So it probably was around 24-25,000 at this point rather than the 12,000 that has been officially reported. You can also see that the total number of deaths on that particular day were actually was actually 42 on that particular day. This is a crude way of looking at the mortality because mortality as a figure actually lags behind 2 weeks to 3 weeks after the new case load. So it's actually not a right way. But if you look at it, just to to put numbers in perspective, this yields a mortality of around 3.5%. Like I said, since this is the number of cases are being underestimated, the true mortality is well below 2% at this point, which is kind of a reassuring figure for us. I'll come back to this later, but please note that the number of vaccinations at this point was 446 only. And then, so what's driving the caseload up or causing this particular spurt? So we know that, when we started, the first lockdown was open, the ancestral strain, the Wuhan strain, if you choose to call it, was the one which drove the initial spike of cases. And in April of that year was the Delta wave. In January of 21 was the Omicron strain. So, this is because this is an RNA virus. The coronavirus lacks, measures which normally prevent errors in replication from happening, which is basically DNA spell checker is absent in this, so a lot of errors happen when this virus multiplies, and the more the virus multiplies in the community, the more the errors likely to happen by random chance. This is how these strains have evolved over time, and the Omicron wave, which we had in January, gave birth to two subvariants, the BA1 and BA2, and then the BA2 subvariant itself then has two major subvariants. And then recombination happening between these particular subvariants, some deletions happening as the strain kind of evolves in relation to infections, immunity happening in the community as well. So this is how, for example, the 3D crystallographic appearance of the Omicron Omicron variant of the COVID virus would appear. And you can see that the spike RBD has several, these red dots are where the new mutations have been kind of noted for this. And when the Omicron variant appeared first in South Africa, this was a big cause of concern because the receptor binding domain is when you have a lot of mutations happening, then there is a significant chance of immune evasion, which means that significant, higher severity. But what it actually finally translated to was also, that there are two things happening in a virus. One is immune evasion, and second is the ability to bind, and and then the severity. So this in evolution, where the two things actually are opposite to each other. So when you have if you have something which is extremely likely to kill, it's less likely to then get transmitted and persist in the community. Whereas something that is likely to evade immunity is likely to cause, and then it's less likely to be a fit strain. So which is what has happened with Omicron. So we didn't have that much, fortunately, and then most of the population was already vaccinated at that point as well. So but as a virus, when it keeps evolving, it does have some different mutations that accumulates in relation to low grade multiplication happening in the community. And in this case, unlike other viruses, there is no other host except human beings who get infection. So the XBB 1.5, the Kraken variant, as it was called in the press, was basically then a recombination of the variant BA1 and BA2, and then that kind of drove cases a little bit up a blip earlier last year, up somewhere around November, and then in several other countries much later as well. But the so-called the current wave is because of the second one that you can see below, the XBB .1.16, the so-called Arcturus variant that the press has chosen to label it. So that is basically a recombination of two BA2 subvariants with some mutations extra as well. And this is what is currently driving, because this is now able to evade immunity better, and then cause more kind of infection. So it's more infectious as a variant. But this has happened in the background of almost everybody in the population having been exposed to Omicron, and that being the dominant virus at this point. Very recently, that is 2 days or 3 days ago, the WHO chose to upgrade XBB.1.16, which is the current variant in India, as a variant of interest from a variant under monitoring, which basically means that they're looking at it more closely, and its chance of it causing more kind of outbreaks in several countries where it's not currently circulating. So that is what is driving the caseload up at this point. So the next question are symptoms very different? Now, the symptoms are likely to be dependent on COVID per se, and not particularly about the variant. So fever, severe fatigue, sore throat, running nose, some loss of smell, joint pains, GI symptoms. We've noticed a couple of patients then presenting with pink eye and presenting with conjunctivitis related to COVID, and that was a feature that was not so common earlier, but we kind of noticed it with this particular spurt in cases. Apart from that, but however, there's no specific symptom that will distinguish other variants from this particular variant, nor are there symptoms which will distinguish COVID from any other particular respiratory virus that is circulating in the community, because the prototypic symptoms for any infection are not dependent so much on the virus, but they're dependent so much on the on the patient's clinical features. Like physiologically, we can only have so many symptoms for a given disease state. So question then comes as to where we are heading to. So the classic example that we would turn to when we are dealing with respiratory viral this thing, and then for which we have a lot of experience now, is the influenza virus. So the influenza virus is not to be exact, they are not almost the same, but they are all mRNA viruses, and slight differences in the sense that the influenza virus is more complex. It has other hosts apart from humans, so there is also a chance of inter-species mixing, leading to a major strain evolving. Not so much a problem with COVID, but in influenza, there are two things which happen. One is the strain that is circulating in the community kind of slowly accumulates new mutations, and then that is called drift. And when that sufficient drift happens, then the population loses its immunity, and then there is a burst of cases happening. This is kind of happens routinely every 3 years, 5 years. For example, 2015, 17 was a spurt of cases. In fact, this year we had a burst of influenza cases more than the usual baseline. For example, on a simple influenza year, we typically as a country have about 4,000, 5,000 cases. On a bad drift case, we kind of have about 25,000 to 30,000 cases, and mortality consequently is also dependent on the total number of cases. So this is also something that should be tracked. Uh, in influenza, another thing which happens is when there is a new strain which emerges due to mixing between species kind of strains, and then there is something which suddenly appears in the community for which we have no immunity. For example, when COVID first appeared in the scene in 2020, we as a population had no immunity, which is why all this lockdown and all this scare happened. The same thing, is true for going forward for COVID. We would likely have some sort of new combinations, sublineages, mixing, new couple of mutations which will be going on, and there will be seasonal ups and bumps in the kind of this thing. Typically, this will happen at least once a year going forward. Like for example, it happens in influenza. It's unlikely to go away from the community. So we already there is significant monitoring in place for monitoring all of this. So as a for a layperson, what's important is to track basically if the case load is going up, and if the case load is going up, to intensify our personal protection measures, which basically always are fivefold, basically, which is masking up, hand hygiene, social distancing, making sure we vaccinated, and then if we have symptoms, to self-isolate ourselves, test and follow appropriate treatment proposals. So that would always go forward. Now, what as a community we should be more aware of and be attuned to is also that we could potentially have a new variant, for example, the Delta, which happened, appear, for which we as a community don't have much immunity, and then that can cause major havoc. So the chances for that happening with COVID are pretty low. At the moment, vast majority of the population worldwide are kind of vaccinated already. And this is unlikely to happen unless there is low-grade, prolonged multiplication happening. That typically happens in immunocompromised people. And for example, the Omicron is believed to have started in immunocompromised population like HIV population with long-standing low-grade COVID multiplication in South Africa. So this is what, as a community, we need to basically tackle to prevent those kind of infections, and as a community, as a healthcare community as well, to treat those cases better so that new strains don't kind of evolve. And also to be aware that not all cough, cold are automatically COVID, that there are several other respiratory viruses. For example, this particular season, we've had a triple whammy in India as well. We had a lot of influenza. We did have COVID, a bit related to the XBB.1.15. We also had a lot of respiratory syncytial virus, and the same has been the experience in Canada and US as well. So if you look, you will have the evidence of those cases, and not to assume that everything is COVID until proven otherwise. We did, for example, a month or 2 months ago, have a lot of conjunctivitis and respiratory symptoms in children, a spurt of cases in Chennai related to adenovirus respiratory infection as well. So, a lot of these are happening, and then it's just the, as healthcare after COVID, we are now more attuned to look for them, because earlier we never used to test to really know. Now we are always aware that this can spread and this can cause havoc. So we have better diagnostics. PCRs are far more widely available. The cost has come down. So it's easier now to test and treat. So then that leads to the next topic. Where are we with regard to testing? So I already pointed out this particular low kind of figure that we were significant under testing is happening, and that is kind of anticipated. This is what is happening even when we were in the midst of much bigger waves. At this point, however, we have several approved, ICMR approved home testing kits, rapid antigen kits, which are extremely widely available off the shelf, which we can test ourselves at the home. We do have to kind of reference test the RT-PCR, which has always been available to us for the last 2.5 years almost now, which tests at least for 3 particular genes of the of the coronavirus, the spike, nucleocapsid, and the envelope. Typically, several of these kits also look at this particular RDRP region, which is the open reading frame 1 region of coronavirus also. With regard to the Omicron, because of the particular, like mutations seen in the spike region, those kind of kits are not typically there. Those genes are not only there in the ancestral strains. So the PCR kit often doesn't detect the spike gene of the, but it will often detect the other two, the envelope as well as the nucleocapsid antigen, gene product of the coronavirus. So you'll have the S gene drop out with the Omicron. That is true of the particular sublineages of the Omicron as well. So that's the easy screening way of looking. Not very great, not very sensitive, but fairly okay way of looking at whether this thing at this point, it will not tell us whether it's Omicron or any of the sublineages, because virtually all cases that we have are Omicron at this point. So no one's actually looking at whether there is any S gene dropout or not. We were looking for this in January 22, though. We do have another test, Nadu, that is widely available and available in quicker, time frame. So the TrueNAT test, which we can theoretically get the result back in 2 hours. So it's based on it's a chip-based RT-PCR again, run on the versatile expert platform. So this again, is widely available now in India. So where are we with regard to like what is the yield of all of these tests? And this is something that is timing. A lot of people are kind of stressing about this. With rapid antigen tests, the sensitivity overall is about 6 out of 10 with very good specificity. So if you pick up a case, you're likely to be right. So you do a test and then the rapid antigen test picks it up. It says you have COVID. You don't need any more tests. All you need is to self-isolate and see whether you're mild, moderate, or severe risk. That's what you need to do. You don't need any more tests. But if it doesn't pick up, that's a question. And that is especially true if you're asymptomatic. So the yield of the rapid antigen test is very low. It's even lower than tossing a coin. So you definitely need more tests at that point, especially if you have symptoms or you have reasons to worry. So for example, you have some health issue, or a family member has health issue and you're worried if you will spread the virus to them, then we definitely need a better test. We all know the RT-PCR is the standard test to pick up COVID. However, there are a lot of fallacies that can happen into the test, starting from what is the day after exposure, how symptomatic or asymptomatic the person is, how reliable the kit is. And even though, the RT-PCR there is really no the gold standard to diagnose COVID. RT-PCR, so several studies have shown that the yield can be as low as 60% if you, for example, you test within first day of exposure from somebody who has minimal symptoms. So these are things that to be aware, and then we've all gone through this in several waves. I'm just reiterating this for sake of this thing. So I still have patients coming and saying, no, I was RT-PCR negative, so I really didn't bother. And then 2 days later, my grandmother developed high-grade fever, cough, and then we tested her and she was positive. So this is what you need to be aware. If you have symptoms suggestive of COVID, you are exposed to somebody of COVID, you don't need to test yourself. If you're low risk, you should assume you have COVID until proven otherwise, and put in those measures which will prevent you from spreading this disease to other people. So that is one of the cornerstones of the 5-arm strategy to prevent COVID transmission in the community, which I spoke about earlier. So for TrueNAT, of course, data is scarce. Small studies show 100% concordance with the RT-PCR, but there are few discordant studies, so more data is actually needed. So then, where are we now with regard to treatment options? So this is the kind of the National Task Force guideline. This is a busy slide, so I'll go through it in bits and pieces. So when you have mild disease, which is people who have fever and some cough, but no breathlessness or hypoxia. So again, it's important to test yourself to see whether you have any unusual heart rate, unusual low oxygen. So most people, that is almost 90% of people, will fall in this kind of group. And especially if you have no risk factors for severe disease or mortality, which is if you're not more than 60 years, you don't have any respiratory or cardiovascular disease, don't have any diabetes or health immunocompromise, you don't have any active tuberculosis or chronic lung disease of any other organ, and you're not obese or you're not unvaccinated. So these are not there, then you should do home isolation and monitor yourself and seek immediate medical attention if you have any symptoms. So I still have people who, are still worried because of persisting cough alone, but not necessarily because of other things. So you have cough alone can be because of chronic sinusitis, which is well, a known recognized kind of a symptom after Omicron. So if you have persisting cough beyond 2 weeks after something that looks like a COVID, then you need to see a physician to get yourself tested, and then use some therapy for your cough. Otherwise, not really. If you have mild disease, nothing to worry. And of course, not to make sure that you're not using any of these kind of unapproved or therapies which have no evidence, like hydroxychloroquine, ivermectin, plasma, neutralizing antibodies, etc. And of course, molnupiravir also has not been approved by ICMR, even though there's some data, because the efficacy is very, very low. Very importantly, azithromycin not to be used. It's a viral disease. Azithromycin abuse in the community will lead to widespread azithromycin resistance for bacteria in the community. So when we really need azithromycin, it will not work. So make sure you pass this message along. Do not use azithromycin for respiratory viral infections. And if there's any one message that I would like to pass on from this particular talk, that is this: kindly do not use erythromycin or azithromycin for respiratory viral infections. And when we call moderate disease is if your breathlessness is there or your saturation is about between 90 to 93, then you typically need to admit these people because you're worried about the trajectory of the disease. So we would usually if it's hypoxia or saturation is less than 90, then you use oxygen. And if there is hypoxemia, we typically give them steroids. We try to keep the steroids as low as possible and as low dosage and duration as possible. And then most people we prefer oral therapy unless there is a strong reason not to offer them oral therapy. We don't typically offer them anticoagulation unless there is strong risk factors. In fact, because it's a dual-edged sword. I've had people, who lost people, family relatives in the second wave due to pulmonary embolism, now landing up and then strongly asking for D-dimers, unfractionated. But unfortunately, everything that we do has benefits and risks. So you can anticoagulate and then still lose patients due to bleed or other things. So the strong evidence that people with moderate disease who are not bedbound do not need anticoagulation. So that is something that to be stressed again. And severe disease, of course, apart from steroids, oxygen, supportive therapy, remdesivir, other options, we don't have that many. Our antiviral and cocktail antibodies have now gone away. They have no efficacy with the Omicron wave. We don't really have more effective antivirals apart from remdesivir. We do have some therapies for people with hyperinflammatory syndromes. We've not seen that many of these, both with the Omicron wave or with the current wave. So really not given anybody tocilizumab in the last several months. And these are two new antivirals which have kind of been approved. Nirmatrelvir boost combination with ritonavir. Now that is something that basically was developed by Pfizer. And in India, we have 4 generics who have now got a license from Pfizer and now making it available. Now, what has happened, however, is with lot of the huge caseload in China, all of these medications got really exported to China, so it's not really widely available in India, even though most of these medications are manufactured in Hyderabad, etc. So it's kind of quite difficult to get these medications, basically Paxlovid generics in India. And then personally, I don't use molnupiravir because the absolute benefit is quite low for most people. So then, which leads us to the last question: what about vaccination? At the moment, we have 12 vaccines which are approved for use in India, and apart from Covishield and Covaxin. I'd like to point out here that Covaxin is approved for everybody above 5 years, so children as well. And these have been the backbone of the vaccination program. You have a Russian company approved for more than 12 years. And these are the other vaccines which are now currently kind of come into the have been approved by DGCI. So Covax, which is basically serum, got this particular patent from vaccine basically. and it's approved for more than 5 years. Corbevax again is another vaccine launched by Biological E, basically on a patent from Texas Children's Hospital, again approved for pediatric age group more than 5 years. It's a protein subunit COVID vaccine. And then we have this Janssen vaccine, like single dose vaccine launched for more than 18 years of age. It's similar to, like Covishield, for example, adenovirus protein, which is linked to a spike protein. And then we also have these 3 new players in the market. Zycovid, which is basically a unique vaccine developed by an Indian pharmaceutical company. DNA plasmid vaccine, which is given intradermally using a special injector, so no poking, spring powered injector, approved for somebody more than 12 years. We have this unique intranasal vaccine, not so unique as in respiratory virals. We have a respiratory viral vaccine for influenza nasal vaccine as well. But this is approved for adults as well, so that's unique. Incovac, developed by Bharat. And then we also have India's first mRNA vaccine developed by Genova, which is also unique in the sense that it's stable at 2 to 8 degrees, which is a big problem in the subcontinent, as opposed to say Pfizer, which needs -40, and Moderna, which needs -20. So Gemcovax. Now, but where are we with regard to availability of all of these? Now, the problem is that vast majority of the population has already received 2 doses, and a significant proportion of population, eligible people, that is people more than 60 who are immunocompromised or healthcare people, have already got a booster dose as well, or a precautionary dose, should you choose to call it that, have got that as well. So there is what really happened was that the number of takers for vaccination really before this particular spike of cases really dropped down, especially after January 22. So a lot of the stocks that were lying around really expired. So even for Covaxin and Covishield, it's been quite difficult to get doses of vaccination for people who really require or who haven't really taken the precautionary dose, say, for example. So the problem at this moment is really there is no clear schedule in India about further precautionary doses. And like I said, we are already over this particular spurt of cases. So really, there is probably, by the time the immunization happens, we will probably be over this spurt of cases. So what we need to look at as a healthcare community is really, how frequently to vaccinate. For example, in influenza, there is a strain monitoring which happens every year, twice actually, by the WHO, and every year the vaccination recommendation changes, and then we do vaccinate people with respiratory diseases and people more than 65 every year annually. So is that something that we need to do for COVID? Is something that we need to really look at, or probably we need to do if there is a spurt and uptick of cases which is sufficiently different from the existing one. So this is something that we as a community, as a healthcare community, need to sit down and have a consensus. I'd also like to end this saying that there is no Omicron or bivalent vaccine in any of these vaccines. Serum was at one point really interested in, and they said they could produce a Omicron vaccine very quickly, but that did not happen. In the US, both Pfizer and Moderna have launched bivalent vaccines with 15 microgram of either strain, the ancestral strain and the Omicron strain. But what really happened was that the bivalent vaccine was not greatly superior. The efficacy was hardly 15% different from the monovalent vaccine. So even though it's been FDA approved and currently monovalent vaccines are not available in the US, there is no huge kind of improvement over a monovalent vaccine, which is basically me saying that there is no real reason to turn away from our existing vaccines. We don't really need to, at this point, to tweak our vaccinations. We've actually got our original vaccinations, we are well protected, and all of us have actually had a booster with the Omicron wave. Virtually all of us have not only got a precautionary vaccine, but then we also had a booster in terms of a natural infection with the Omicron wave, which kind of has boosted our anti-immunity quite high. So unless there is a significant change in the viral clade or something, then we really need to look at that. But at the moment, there is really no need to go into bivalent vaccines. So I'll stop at this moment and then take any questions.
Thank you. Thank you so very much, Doctor. I think there are a lot of questions already in the chat box. Madhu, would you like to read out?
Yeah, I'll read it across, ma'am. Just a minute. I'll just open it. I'll read it in the first question that's posted. 1 minute. Yeah, first, Doctor, the first question is, are there any new type of precautions recommended to keep away from new variant?
So no new precautions. The precautions are always the same. The precautions depend on the virus, not so much as the variant. Given variant may be slightly more infectious, which only means that you need to keep up the what we're doing in a more consistent manner. Otherwise, our strategy is always fivefold. So make sure you are masking, hand hygiene, social distancing, vaccination, take your precautionary dose if you need to, and then self-isolate if you have symptoms. These are the 5 things that we need to do.
Thank you, doctor. And this is actually from a individual case. He has mentioned, I was affected in August 2020, and doctor claimed lungs severely affected, 15:25. I had taken 3 vaccinations. Now, even if I sneeze once, I develop itching in a throat with coughs, which was not before COVID. Does it mean my lungs are not fully recovered? If I climb the stairs, I develop itching in throat. Please advise.
Right. So in August 2020, there were no vaccines available. So at that point, it was natural for once the lockdown opened for people to get COVID. So that was unfortunately, I suppose, what happened. And then I see that he had taken 3 vaccines. So I'm assuming then he did get Omicron. Now, we know that vaccination protects against moderate to severe disease, almost 95 to 99% of the time. But it does not really protect against infection. And especially with Omicron, the efficacy of vaccination, even after the precautionary dose, is lesser than 60%. So what we need to do, even if you're vaccinated, is to stay on top of all five measures that we've already spoken about. And again, not to, once you have symptoms, not to bother so much about the symptoms, but to make sure that you don't have any severity of manifestations, which is what I pointed out during the clinical features. Now, the symptoms that you are describing are typically that of sinus symptoms, which is something that happens after Omicron frequently. So all you need to do is to go meet your pulmonologist and you'll be okay in no time.
Thank you, doctor. Then actually there are 2 questions, similar ones. So I'll read the one that is talking about the masks. It says different suggestions are given for wearing mask. Some say once you move out of the house, wear it. Some say do not wear when you go for a morning walk as it may create breathlessness. Others say do not wear the same mask for the second time once you remove it. It is confusing. What is the correct method, doctor?
Right. Good questions. So all of these are questions which have been common across our waves. So now when you need to wear masks when you're outside the house, especially, and this is especially true in situations when there's a lot of transmission happening in the community. Now, if the transmission is low, then for example, when the transmission was low for COVID, the mask directive was taken off, and then, for example, now if you're traveling on a flight, it's not mandatory, though it's recommended to wear your mask. So it's personally self-protection. So I would normally wear a mask in spaces where it's closed and there's not much ventilation and you're likely to be in close contact with others. But not so much when you're outside and you're not likely to be in such close contact with us. For example, if you're in a park outside, it's not overcrowded, which is a well-ventilated and open space, then the real necessity for actually wearing a mask is low. And especially if you're exercising, it makes no sense because you're going to be having a higher minute ventilation and you will feel a bit choked through the mask, especially if you're not used to it. So wear masks in closed spaces, definitely, and wear masks when you're not exercising, definitely. So this is what I would say. And what about masks? How frequently can you reuse your masks? It's important not to touch your mask, because that's where the microbes you're exhaling will be. So if ideally all these disposable masks, especially if you're not using an N95, you should be able to dispose it every day, ideally. But if you are using an N95 from the pandemic, we've kind of reused N95 for about 3 to 4 days during the pandemic. When the waves were, pretty high, and then even masks were a shortage, we used to basically get the N95, leave it out in a place where people are not, too dry, and then when it dries, to reuse the same mask. So we used to rotate N95s in a 4-day rotation, and there's data from AIMS that this is a fairly okay. So that's what I would basically do. If you're worried about and then you're using, but if you're using a simple mask, I would generally dispose it every day.
Thank you, doctor. And there are some similar questions, so I'll read the one which is the same clarifications. It says, any additional meditation required to improve the immune system for those affected with COVID, especially children below age of 15 years? That's one question. And in the same question, he is asked, any side impact of vaccine? Is it required to take an additional booster now?
Right. So it's common, and it's people think of immunity as one thing, but unfortunately, immunity is not like one organ, like a heart or or lungs or a pair of lungs or a pair of kidneys. Immunity is a very complex thing. There are several arms of immunity. You have an innate immunity, adaptive immunity, and you have pathogen-specific immunity. Now, when you're speaking about general improving immunity, all you can do is to basically sleep well, eat well, and exercise well. This is what you can do. There is no evidence that popping vitamin pills, etc., actually add to your immunity. What it will do, maybe give you peace of mind, which will improve your immunity. So I'm not going to detract from that. I will leave it at that. So what really works is to sleep, is to eat healthily. So include a lot of vegetables and fruits, exercise, and sleep at least 7 hours to restore your immunity. And pay attention to what's happening in the community, and follow the health directives that are going around. That is what is essentially true for immunity. Now, are there any negative side effects of vaccine? So there are anything that we do in life. There is going to be expected effects and unexpected effects. So the effects that you don't, or there could be effects that are expected, but something that we don't like, that is going to be part and parcel of it. So if we cross the road, you're likely to get hit by somebody, but we do have to cross the road to go to the other side. So this is part of life. So similarly, when we take a vaccine, there are some things which are expected. So pain in the injection site, some low-grade fever, these are expected, and that is what we call side effects. This happens because the vaccine is actually working, and it's producing immune response. Cytokines are being produced because the vaccine is inducing immunity, and that is what produces the fever. Now, the vast majority, this is simple and easily managed by by topical ice application or taking a paracetamol and then keeping calm. Very rarely, in 1 in a million, a serious side effect can happen. Typically, that is a vaccine-induced neurological complication or vaccine-induced thrombosis. These are pretty rare events, and but the fact is that we vaccinated 2.4 billion or 2.5 billion doses. So even if this were supposed to happen in 0.01, you would still have a sizable number happening. But bear in mind that if you hadn't vaccinated 2.5 billion doses, then you'd have a sizable number of deaths happening due to COVID. And then you can look at the Delta wave as to what really happened. We didn't have vaccines at the time. We had a vaccine virus, which we had no immunity to, and you can see the number of deaths which happened. So, vaccines are safe. Do not focus on the side effects of vaccine. As an individual, the chance of you getting a side effect is extremely low. That's what I would say.
There was one more. Do we need an additional booster vaccine or a new vaccine?
So boosters are recommended if you are more than 60, you have health risk factors which I have outlined in the presentation, or if you're a healthcare worker. So these are the only group of people for which the government approves a precautionary dose in India. And you are eligible after a period of time, that is 9 months after your second dose. So if you fulfill all of this, then you can actually take a booster after registering in COVID for coronavirus in India. If you've not taken a booster earlier, and then we've actually kind of now passed the peak of the current wave, it makes very little sense, because by the time you take this current booster and then your vaccination immunity kicks in, which will be about 7 days from now, the caseload will drop less than 1,000. So a booster is something that needs to be taken when the cases are going up, so that your immunity is on top of it. At the moment, I probably would not recommend a booster for somebody who hasn't taken it at this point.
Okay, Doctor, just 2 more questions, I think, and then we can probably wind up. Actually, Dr. Pratap had mentioned, can you again quickly review the treatment discussion on the 2 slides you displayed? Can we do that, or shall we share the presentation?
I'll share the presentation. It's very simple. It's approved by ICMR, and then it's available for everyone.
Okay, so you can probably share it with us, and we'll share it with the participants. So thank you. And then there's one more again about the booster. Actually, Mr. Jaishankar had said, you mentioned an interesting aspect about the Omicron strain having first developed in patients immunocompromised by HIV. Many people are immunoaffected due to medications taken for arthritis, psoriasis, etc. Do such people need another booster vaccine? So it's again coming to booster vaccine.
So yeah, if you looked at the recommendations for boosters, people with immunodeficiency, yes, we recommend a booster vaccine. Now, immunodeficiency is not an absolute thing. It's again a grade of something. So somebody with HIV with extremely high viral load and a low CD4 count is by definition very, very immunosuppressed. Somebody with arthritis, who's on a little bit HCQS, is actually not immunosuppressed. So we basically need to individualize it by seeing what exactly they are on. People have shown that the vaccination is safe in those with pre-existing arthritis and other autoimmune diseases. So this is something, yes, that they should take if they haven't taken. With the caveat that we are already on top of the current spurt of cases.
Thank you. And I think you already mentioned a lot about vaccinations and boosters, but still there's a question which says, can repeating vaccinations affect the natural immunity and make us dependent on them?
So this comes again back to the question of people having a very I don't know about sense about immunity. So what exactly is natural immunity is what we need to see. Basically, when you take a vaccine, it only induces a virus or a bacteria-induced vaccination. For almost all of us sitting in this presentation would have taken as a child diphtheria, pertussis, tetanus vaccine. Nobody as a child, your parents would not have said no to those vaccines. This is essentially smallpox vaccine, polio virus vaccine. All of these has led to all of these viruses disappearing as a healthcare threat from the community. And we are sitting now and as a country improving our life expectancy because we've been using these vaccines. So, if you take a vaccine, it is specific. It doesn't really kind of change your immunity overall to one particular direction or the other. And then if you take your vaccine, a lot of us also on top of it have had natural infections. That itself acts as a booster on top of your vaccine as well. So this is called hybrid immunity as well. So, so that's what I would like to say. So I'm not sure if I'm able to convince people who already have a different idea about vaccination, but vaccination doesn't really change your immunity for, the better or the worse. It only directs your immunity against a particular pathogen.
Okay, I think, Doctor, you've covered almost everything and we are almost running out of time. So I'll pass it on to Dr. Ayyappan to propose the formal vote of thanks. And thank you very much, Dr. Srinivas.
I think I should definitely say here that we have had free consultations with Dr. Srinivasa Rajagopalan. Thanks for permitting us to do that. Over to you, Dr. Ayyappan, the co-chair of the committee.
Thank you. First of all, thanks to Dr. Srinivasa Rajagopala. Very, very informative session for the vaccination queries and all. We know you are the best in COVID pneumonia in this part of the world. And especially the way you showed the metamorphosis of the virus, how it has changed and how the various waves have occurred. It is very, very informative. Thank you, Doctor. Thanks to everyone who has joined this very informative session, and thanks for the active participation. All your queries were very, very valid, and we all have this in our mind. Thanks to our chairperson, Mr. Jaishankar, and all members of MCCA's Healthcare Committee. This is our first meeting, so it has gone off very well. Special thanks to President Mr. Kesavan, Secretary General Ms. Saraswati, and all members of MCCI who are our pillars of support. This session is just a start of the activities of the Healthcare Committee of MCCI. We have many more in the pipeline, and very soon we'll be announcing them as well. Thank you all, and I wish you all a very great weekend. Thank you.
Thanks.